Uh, Good morning, everyone. So, yeah, a brief classification of keratitis. As the name stands, it means inflammation. Can be, because of local or systemic causes, infectious and non-infectious. So, generally, when we talk about immune keratitis, there is a belief that it has always peripheral keratitis. May not be so. Even the converse is not true. Peripheral keratitis are not always immune. So, we should keep that in mind when you see a keratitis. So, what is important here, we have to understand, normal eye, the limbus is the one that separates the cornea from the sclera, and there is a distinct anatomical and probably physiological features of the limbus that predispose this as the area of immune or other diseases, because of fact features like blood vessels, antigen presenting cells in the limbus and the peripheral cornea, which makes it an ideal place for all the immune reactions. Now, pathophysiology, there is a specific loss of, supposed to be immune tolerance towards the corneal tissues and antigen, and damage is potentiated and perpetuated by non-specific mediators of immune defense. So, the antigens from the cornea gets processed at immune processing centers, and the effectors migrate to the cornea, resulting in all the, the bad effects. In staph marginal keratitis, probably it is the antigens which gets processed at the regional processing center and then migrate back. Murans, you have some systemic issue or some systemic antigens or triggers that kind of causes the effect on the cornea. While in autoimmune disease, it's all the systems that affects. So in any case of keratitis, as as has been explained, let's start with the history, proper evaluation. We may or have to rule out infection here, and then whenever necessary, we may have to get an internist help. So history-wise, look at the take the complete history. It is not just the ocular history which we are bothered here. All systems have to be asked for in detail and then looked for too. But the importance of identifying an immune keratitis is that this might be the first presenting sign of a potentially lethal systemic autoimmune disease. So that is what is very important here. So clinically, there might be some features that help you to differentiate immune keratitis from an infective keratitis, but then this is not always true. In patients with contact lens and trauma, it is more likely to be infective rather than immune. Then symptoms are supposedly minimal, discharge practically not there in immune, lid hygiene can be poor in immune keratitis. History of multiple episodes point towards a immune etiology. Location, again, peripheral, more in favor of immune, but it is not always so. Morphology, all these things, if it is ulcerated, more likely to be infection. But yeah, again, we have all sorts of crossover presentation. So what is important here is, when there is even an iota of doubt, always rule of microbiology, do a corneal scraping, proper microbiology workup is required. And then you think about the systemic alternatives. Generally, I generally don't do any of these. I send them to, if I suspect an immune, mediated, I send it across to my rheumatology colleague, who does all the investigations if required, systemic. Treatment, you have to think about the local treatment and the systemic therapy. Locally, think about infection, inflammation, other local factors, and tectonic support wherever required. Systemically, you have to control the inflammation, the collagenolisis has to be controlled, diagnose and treat the underlying disease. If required, may have to go to immunosuppression also. If there is infection, I have to treat it with antibiotics and or whatever antimicrobials is required. If there is no infection, probably if there is a ulceration, you may have to give a prophylaxis antibiotics and then control the inflammation. So the principles of treatment in immune keratitis is basically, probably we can say, is aimed at promoting the epithelial healing, controlling and eliminating the inflammation, limiting the ulceration and the stromal loss. In cases where there is stromal loss, support the stromal repair and maintain the integrity of the globe. So to promote healing, tear substitutes, punctal occlusion, autoserum tears, as has been mentioned for the, chemical, all these things help. Inflammation, topical steroids is a mainstay. Then if you're thinking in terms of autoimmune diseases, we have to think about systemic steroids or immunosuppressives, where we need the help of an internist or a rheumatologist. Limit the ulceration, reduce the collagenolisis. What is commonly used is doxycycline. The others may have a role if you have access to these. Vitamin C may help here. Then to maintain the integrity of the globe, in peripheral ulcers, especially Moorens, if there is active inflammation going on, you can think about resection, conjunctival resection, along with the cyanocolate glue to support the, the thinned cornea, bandage lens to make the patient asymptomatic. Can consider amniotic membrane graft in such extensive, if thinning, it's not a real great option for tectonic support, but helps in epithelialization. Then for real tectonic support, we have to think about grafts either in cornea or other biological tissues like sclera in various shapes, forms of letters, all those things. Okay, so basically it depends upon where the thinning or the melt is, and what is the shape. Most of the cases we may need to have a freehand dissection here rather than what we are used to using trephines and such. So in nutshell, in immune keratitis, our first role, or any keratitis, the first thing to do is to rule out an infection. The next is to arrive at the cause of the keratitis. Then if it is immune, we have to control the inflammation, both local and systemic, and maintain the integrity of the globe and achieve as normal a healing as possible. Thank you.